Is Mr. Griffith for 5 minutes for questions.
Thank you very much, Mr. Chair. Dr. Jones, I helped lead Section 7161 of the Support Act in 2018 that would support and improve prescription drug monitoring programs. My thought was the money authorized for that was to start up the programs and increase collaboration across state lines. The bill that reauthorizes this section is in front of us today, authorizes an increase in funding. So, can you elaborate, can you elaborate how the money in this program is being spent between agencies and states? And two, if the systems are already in place, we already did the startup from the last bill, explain to us why there is a need for an increase in the funding.
Thank you very much for the question. And through our Overdose Data to Action program, that's how we provide funding to states to support prescription drug monitoring program work. The Bureau of Justice Assistance, who's not here today, is the other federal funder of PDMPs. In our work, you're correct. The systems, 4 or 5 years ago were still getting started in some states or moving from paper-based systems to electronic-based systems. So we've made great progress over the last several years in having electronic systems that exist, having regular and very current reporting from pharmacies to the PDMP, and improving interstate data sharing across. I think where there continue to be opportunities is to integrate the PDMP data into electronic health records, clinical decision support. It's an important piece of information for clinicians to have, and we don't want them to have to go to a separate system that disrupts their workflow. So I think there's opportunity there in better integration in clinical workflow. And then from a data analysis perspective, it's also an important tool for health departments to understand what are overall prescribing trends in a state, how are things changing, where might they target educational resources. So states have used our funding to not only have staff to be able to analyze those data more regularly, but then also to have academic detailers go out and say, here's an area where we're seeing some troubling trends. What might be driving this? Can we help improve knowledge about appropriate prescribing of opioids or other pain management options? Or are we seeing a place where we might want to expand access to buprenorphine because there is a desert for access to MOUD?
And I appreciate that, and I'm carrying the bill again, but I wanted to make sure on the funding side that I had a good defense for it, and you've presented that. Thank you. Mr. Strait, we were just talking about buprenorphine. With DEA's proposed rule on March 1st, 2023, that will ease in-person requirements to be prescribed the controlled substance, a controlled substance via telemedicine, and I'm for telemedicine. That being said, in some parts of my district, it's being reported that buprenorphine, Suboxone, is being used as a street drug, that they're taking some and not taking some. So does the DEA track the prescription patterns, prescribing patterns on buprenorphine, so we can see if expanding the number of patients any one doctor can have and having telemedicine, are we going to be prepared to keep an eye on that to make sure this doesn't become a problem in and of itself?
Thank you for that question. It's a great question. And what I would tell you is that the best experience we have is what happened during COVID when telemedicine flexibilities existed. And what I will say as a general matter is we did not see an increase in diversion or misuse of buprenorphine. I think the other piece is knowing that it's widely dispensed in combination as Suboxone when it's in combination with naloxone tremendously helps toward that end of ensuring that it's not going to be misused.
But so what you're telling me is you are in fact tracking
Absolutely.
it. Okay, good. And in regard to the 3-day rule, and you amend the 3-day rule for dispensing medication for opioid use disorder, do you plan to have a monitoring system in place for that as well?
I'm sorry, the 3-day rule?
Yeah, there's going to be, apparently the Department of Justice is releasing an amendment to the 3-day rule for dispensing so that you can get a longer prescription.
Yeah.
Do you plan to monitor that for abuse as well?
Absolutely. And in fact, we've been granting exception letters in all 50 states to mostly hospitals. That's been going on for about the last year and a half as well, so that they can already, during the pendency of our rulemaking, they can already do a 3-day.
And Dr. Jones, back to you, and I'm running out of time. Can you explain briefly how the CDC's high-resolution libraries function and what research is being done into fentanyl analogs on your end?
This is an active area for our National Center for Environmental Health, where they have really been leaders in developing new testing methods as well as sharing reference materials to public health and clinical labs. So we've expanded beyond fentanyl analogs to synthetic stimulants, benzodiazepines, cannabinoids. We have over 300 in the high reference lab at this point.
I love a longer answer, but my time is up, and I must yield back.
Thank you.